Person-Centered Therapy by Lena Shostakovich, Talitha Peacock, and Linda Gamroth. To begin with, we will address the origins, philosophical assumptions and basic concepts, and key principles of person-centered therapy. Carl Rogers was an American psychologist who developed a theory of person-centered therapy in the 1940s. He began his career in the seminary before obtaining his doctorate in clinical and educational psychology. He worked for 12 years as the director of a child guidance clinic, where he developed the basic principles of his person-centered therapy approach. He went on to work within a variety of academic and research positions, through which he authored many books and articles. He was a founding leader in the field of humanistic psychology. Rogers was one of the first to use the term client to describe the recipient of psychotherapy, which was a beginning step in the move away from a medical model of mental illness. He developed the method of non-directive or person-centered therapy, which suggests the client, not the therapist, is the expert in how the therapy should proceed. Rogers' unique approach to understanding personality and human relationships has been used within a variety of fields, such as psychotherapy and counseling, client-centered therapy, and education and student-centered learning. The foundational assumption of client-centered therapy is the importance of the person. Rogers believed that people are inherently good and creative. He believed the client should be viewed as a partner in a therapeutic relationship, rather than a helpless patient, and their experiences hold a key to personal growth and development as a unique individual. He also believed that everyone can achieve their goals, wishes, and desires in life if they choose. In order for a person to grow, they need an environment that provides them with genuineness, openness, and self-disclosure, acceptance, being seen with unconditional positive regard, and empathy, being listened to and understood. PCT is based on the faith and empowerment of people to be joyful, creative, self-fulfilled, with the ability to connect both socially and emotionally. Carl Rogers believed that people have the tendency to self-actualize, meaning to develop to one's fullest potential. Each individual has unique potential, and we can develop it in different ways according to our personality. Carl Rogers believed that for a person to achieve self-actualization, they must be in a state of congruence. The development of congruence is dependent on unconditional positive regard. Self-actualization occurs when a person's ideal self, or who they would like to be, is congruent with their actual behavior or self-image. Rogers described an individual who's actualized as a fully functioning person. Two primary sources that influence our self-concept or self-worth are childhood experiences and evaluations by others. Self-worth may be seen as a continuum from very high to very low. For Carl Rogers, a person who has high self-worth, that is, has confidence and positive feelings about himself or herself, faces challenges in life, accepts failure and unhappiness at times, and is open with people. A person with low self-worth may avoid challenges in life, not accept that life can be painful and unhappy at times, and will be defensive and guarded with other people. Rogers believed becoming a fully functional person was a process in which we are open to new growth experiences and feelings, trust our feelings and thoughts as guides for our choices and actions, and have positive self-regard. When we are self-actualized or fully functioning, we are able to make healthy choices and set goals for ourselves that are congruent with our personal possibilities and potential. Rogers believed that people are essentially good, and that the therapist should possess a basic sense of trust in the client's ability to move forward in a constructive manner if conditions conducive to fostering growth are present. Human nature is a product of environmental and societal factors, as well as heredity, early development, and an innate self-driven striving for growth throughout life. This approach sees human nature in an extremely positive light. Distress is caused by discrepancy or incongruence between the self and the experience of the person. All distress and dysfunction are viewed as ways of relating to the world that arise from incongruence. Rogers believed that there were 6 conditions which were both necessary and sufficient to provide the context in which a client could effect change in their life. He believed that these 6 conditions, maintained over a period of time, would be enough to effect change. In the first condition, he identified a relationship, and in the following 5 conditions defined it. 1. The therapist and client are in psychological contact. 2. The client is vulnerable or anxious, in a state of incongruence. 3. The therapist is in a congruent or integrated state. 4. The therapist has unconditional positive regard toward the client. 5. The therapist has and communicates an empathetic understanding of the client's internal experience. 6. The therapist is able to communicate a sufficient degree of empathy to the client. Rogers explained the incongruence of the client in step 2 as a discrepancy between the actual experience of the organism and the self-picture of the individual, insofar as it represents that experience. An example of this would be a mother feeling sick when her son is about to leave. She experiences her illness as proof that she needs care, and so he shouldn't leave her. The actual cause of the illness is her dread of him leaving. The client may not recognize these incongruences, or may only be partially aware of them, but in any case, she's vulnerable to anxiety. In regard to the fourth condition, Rogers acknowledged that unconditional positive regard was a matter of degree in practice. A therapist might experience conditional regard for a client in a particular moment and still offer effective therapy. As in most aspects of relationships, unconditional positive regard was a matter of degree, of having many moments of positive regard toward the client. The therapist should allow the client to express negative feelings as well as positive, and appreciate that the client has permission to have their own feelings and experiences, without losing the therapist's unconditional positive regard. In the fifth condition, Rogers emphasized the as-if aspect of the therapist feeling the client's emotional state. The therapist was not to take on the emotions of the client, but to experience them both empathetically and objectively. In the sixth condition, the client must experience at least a degree of the therapist's positive regard for the therapeutic process to begin. All conditions, except for the first, exist in degrees. Rogers believed that the essential conditions should be offered to all clients, regardless of issues the client was facing. He believed that clients might use the conditions differently, but that they were essential for therapy to happen. He also believed that conditions 3 to 5, which relate to the therapist, would need to be developed experimentally rather than intellectually. They were something that the therapist would learn by doing, not in the classroom. He believed that diagnosis was not necessary for therapy. In fact, he believed that a diagnosis before the commencement of therapy may be most beneficial to the therapist rather than the client, because it might help the therapist to be more understanding and accepting of the client's experience. In person-centered therapy, the therapeutic relationship is the primary agent of growth. The therapist acts in a non-directive, reflective way and should have genuineness, unconditional positive regard, and empathetic understanding towards the client. The client directs the focus of each therapy session, and during the therapy, the client develops self-efficacy, power in their own lives, and a deeper experience of life. The key principles of person-centered therapy are that if a client experiences genuineness, non-judgmental caring, and empathy in their relationships, they can achieve their greatest potential. The focus of the therapy is on the person, not the problem. The conditions necessary for positive growth are empathy, congruence, and unconditional positive regard. The client is encouraged to live in the present moment, learn to accept themselves, and to strive to reach their highest potential, understanding that there must be congruence between what one wants and what one actually is, to recognize themselves as the agent of change, and believe that they have the capacity to resolve problems without interpretation and direction from the therapist.
I am very fortunate, and the client is very fortunate, if I can feel I really accept you fully just as you are. Sometimes that's very difficult. I held an interview with a young man in South Africa. I didn't know anything about him. It turned out he was an officer in the South African Army. Now, for me, that meant it meant that I stretched my empathic abilities to their very limit to try to be with him, to try to understand him, to try to be caring toward him. I didn't feel I did too well. And yet, I've learned since that interview really changed the course of his life. So I feel that if I can be genuinely understanding, try to listen not only to the words but to the meaning, trying to understand the person that's hidden within each one of us, that's helpful. If I really care about this person, in an unconditional way. That's helpful. If I can really be myself in the relationship, not a professional expert, not a, quote, psychologist, not a psychotherapist, just me in that relationship, that's helpful. All those things are possible, and when they come together, that creates a very powerful climate for change, for growth, for drawing out the potential of the client.
We'll next look at therapeutic techniques and procedures. This section will examine the overview of person-centered therapy, phases of treatment, and applications of treatment. According to Raskin and Whitty, person-centered therapy has no rules. It is non-diagnostic, non-directive, and process-orientated. Healing occurs as the result of this collaborative relationship. This means the therapist does not provide a diagnosis. Therapy is not used to solve a client's concerns, and the therapist is not expected to provide reassurance or advice. Rather, the therapist and client enter a personal working alliance. Within this relationship, the client is the architect of the therapy. He may behave in any way he chooses, asking questions, sitting silently, erupting with emotion. All is permissible within this therapeutic relationship. The client also decides the number of sessions, if or when to invite additional persons into the session, as well as if other resources might be helpful in generating positive change. The therapist's role is to receive the client with unconditional positive regard and empathy, and to respond to the client with genuine openness. Godfrey Barrett Leonard lays out 5 possible phases of person-centered therapy: the beginning, the entry, forging a personal working alliance in the passage from woundedness to hope, trust development and the quest for self, synchronous engagement and the becoming self in action, and termination process, ending and entry. While Barrett Leonard illustrated 5 possible phases, Rogers made clear that person-centered therapy is non-prescriptive. Rogers' method of reflecting, for example, may not be how another therapist would or should approach this strategy. The therapeutic alliance guides the process of therapy, and as a result, therapy may look different client to client. Barrett Leonard also clarified that the length of the stages vary from client to client, and therapy may end at any point. Phase A of the client-therapist relationship begins with informed choice. The client, having sought out a therapist to help with a personal difficulty, must understand the therapist's approach to therapy and agree to be there. During this phase, the client may recognize a personal challenge and particular feelings that arise in regard to this challenge. This conversation should move from a rehearsed monologue to a duologue, where the client enters the moment, becomes aware of the therapist and her role, and feels heard by the therapist. At some point, the therapist and client should begin to feel their relationship matters. They both want to be there and are both engaged and present. This phase may take more than one session, particularly if the client is unfamiliar with person-centered therapy. Once this understanding occurs and the relationship has begun, therapy moves to the next stage. Phase B has 2 concurrent branches. The first involves forging the therapist-client relationship and is crucial to the therapy's success. This branch is when the client begins to view the therapist as an ally, and the therapist begins to see the client as a whole person rather than a string of feelings. The second branch describes client concerns. Barrett Leonard acknowledges that clients come to therapy when a previous emotional injury has resurfaced. Although this event happened to the client, he may have absorbed it as part of himself and react accordingly with anger, depression, or worry. This phase of therapy is when the client is able to discern a way forward. The shift may be slight, but even so, it indicates the client is generating hope from within. Trust is the guiding principle of Phase C. The therapist builds this trust through continuous empathetic and unconditional positive regard. It is within this trusting relationship that a client can deeply explore his inner self and recognize his inner locus of control. Knowing that the therapist holds no judgment or criticism, the client is free to share, unburdened by any expectation on his behavior or beliefs. The therapist, on the other hand, is actively companioning the client. In doing so, she also is free to respond to the client in a way that reveals herself to the client. As this phase ends, the 2 branches from Phase B merge. This is also a time when many clients choose to terminate therapy, as this phase is where the client experiences the most change. The transition from phase C to phase D is qualitative, but when it does occur, congruence is thought to be achieved. According to Barrett-Leonard, the client now speaks freely and has words to express his inner world. This is a sign of wholeness. He is also noticing personal changes. This means he is able to live more in the moment, has a better sense of his identity, and can examine past events without lapsing into emotional turmoil. There's also a noticeable increase in poetic language, such as metaphor. Barrett-Leonard attributed this change to the client's left brain becoming more engaged. Phase D also results in intrinsic termination. The client's crisis has receded, and he is now practiced in looking within in order to respond to what occurs outside in life. The client is also sensing the therapist's shift towards termination, and he, the client, feels ready to let go. At this point, the client is less vulnerable and has more actualizing tendencies. The transition from phase D to E, termination, is often practical, based on financial, time, or scheduling concerns. Phase E occurs when the client and the therapist know each other the best. It is why client and therapist perceive the end of the therapy as a real separation and spend time sharing the importance and meaning of their relationship. While there may be some sadness, there is no true sense of loss. In all likelihood, the therapist will remain open to future contact, with the possibility that the therapist-client relationship merges into a genuine friendship. According to Barrett-Leonard, there is no prescription in client-centered therapy against actual friendship. However, most clients and therapists end their relationship at the natural close of the client's initial concern. The aim of person-centered therapy is welfare and psychological growth. Specifically, person-centered therapists are concerned with universal fears that arise in the course of a life: change, loss, love, and the search for belonging. In order to respond to a client's needs, a variety of treatments has arisen. These include play therapy, student-centered learning, couples counseling, and child development. Virginia Axeline was Rogers' student and pioneered play therapy as a treatment for children. Barrett-Leonard described Axeline's therapy as initially structured. The therapist instructs the child on the length of play and not to harm himself, the therapist, with the things in the room. The child is then left to play and express himself as he so chooses. Like one-on-one person-centered therapy, the therapist provides unconditional positive regard, while not crowding, probing, or questioning the child. Instead, the therapist speaks to the child about the child's expressed emotions in a way the child can understand. Over the course of the therapy, the child learns he is able to self-actualize and self-direct. The student-centered learning theory is based on the person-centered and constructivist learning theories that emphasize the learner's critical role in constructing meaning from new information and prior experience. Student-centered learning is a method of teaching that shifts the focus of instruction from the teacher to the student. The goal is to put learning in the control of the student rather than being teacher-directed. This method of learning puts students' interests first, recognizing student choice as central to the learning experience. In a student-centered classroom, students choose what they will learn, how they will learn, and how they will assess their own learning. This is a contrast to traditional education, in which the teacher directs in an active role and the students have a more passive, receptive role. Student-centered learning requires students to be active, responsible participants in their own learning, and with their own pace of learning. The first element, as described by Rogers, is that the learning must have a personal connection which involves the whole person, including emotional and cognitive aspects. The second element is that learning must be self-initiated. The motivation must come intrinsically. The third element focuses on the pervasiveness of the learning. Has it created a change in attitudes or behaviors of the learner? The fourth element is that learning is evaluated by the learner. In other words, has the experience met the needs of the learner? Finally, the fifth element of learning is the foundation of meaning, or rather, meaning is built on the learning experience as a whole. Person-centered couples counseling is used for couples experiencing distress in their relationship. These individuals enter therapy and learn through modeling and practice how to listen to each other. Listening, in this case, refers to an individual's ability to understand the other. This understanding can be demonstrated through accurately reflecting responses. In that moment, the therapist's role is to provide support for the listener. Overall, however, the therapist behaves with curiosity and empathy, understanding that the clients will decide the therapist's role during the session. Homework is a useful tool in couples counseling, and that clients will often practice listening and reflecting outside of the therapist's office. While this practice reinforces what was learned in therapy, it also provides the client with a technique for when they return home. PCT in early childhood classrooms focus on developing a trusting teacher-student relationship within a safe and supportive environment. Once the relational bond between a teacher and student is established, the potential to promote change within the student is created and fosters the development of regulation skills. The relationship established between the student and teacher creates an environment for the child to explore, grow, and develop regulation skills in a safe and caring way. The treatment for children with anxiety disorders using person-centered therapy can be divided into 3 treatment stages: the beginning, the middle, and the end. The beginning stage involves creating a therapeutic relationship based on positive regard and empathy. The middle stage of therapy focuses on helping the child develop their self-reflection skills to acknowledge their anxious feelings and create a dialogue connecting the child's source of anxiety with the courageous and successful strategies used for coping. In the end stage of treatment, the therapist will reaffirm trust in the child's identified abilities to acknowledge and manage anxious situations. The case study included in our textbook, Current Psychotherapies, occurred between a young female master's student from Europe living in the US as the client and an older female therapist. The client was planning a trip to see her parents after being estranged for several years. The client recounts seeing a woman in the street which reminded her of her mother. This caused the client to begin to think of her mother as a person, fearful and diminished, rather than the domineering woman she had known her to be. As the session proceeded, the client was able to let go of her anger towards her mother and anticipate offering care to her as she aged. She also moved from viewing her mother as a figure to understanding her as a person. Interestingly, this was the first female therapist the client had been willing to work with. In approaching PCT as a therapist, it is important to be aware of 2 types of errors that can occur. They are those of understanding and those of attitude. Errors of attitude are failures of a therapist to maintain the necessary and sufficient conditions. Errors of understanding occur when the therapist fails to understand the client despite a genuine attempt to maintain the conditions. In successful therapy, the therapist allows the client to direct the therapy without prompting the client. The therapist exhibits empathetic understanding, and as the therapy progresses, the client experiences a deepening sense of self-efficacy and power in their own lives. In the summary and evaluation section, we will look at the strengths, limitations, and criticisms, as well as the application of this theory with diverse populations. Person-centered therapists seek to empower the client through empathy, unconditional positive regard, and transparent communication. According to Rogers, as the client feels more empowered, his self-concept becomes more positive, and he becomes more self-directed and self-expressive. As a result, the client's ability to cope with stress improves as he becomes more open and free. Person-centered therapy has also increasingly become the standard for quality in healthcare and human services, as well as policy reform in Western countries. Person-centered therapy is based on human connection and allows an individual approach to therapy. This means the clients are considered to be experts in their own lives. They can make choices for themselves and ultimately direct their own therapy. In this way, person-centered therapy is regarded as a caring alternative to the medical model. The influence of person-centered therapy, particularly a therapist's approach, is also seen in much of present-day counseling. Accurate empathy, as seen in process experiential psychotherapy, and inward reflection, as seen in experiential psychotherapy, are two techniques that have been influenced by Rogers. Furthermore, there has been reported success in using person-centered therapy with schizophrenia and psychopathy. Some of these patients, who presented with suspiciousness and hostility, responded to the non-directive and non-judgmental approach of person-centered therapists with positive growth and personality change. Conversely, therapists found that person-centered therapy, when used in conducting crisis work, helped them to be present and in the moment. Consequently, the therapist experienced the clients as more vulnerable and open. These therapists also became more emotionally and practically supportive of their clients and noted that person-centered crisis therapy progressed faster and with greater relational depth than non-crisis work. There have been several criticisms of person-centered therapy. The first criticism is that it is biased. Lago positioned this bias within the therapist, arguing that race, gender, sexual orientation, class, disability, religion, and age will have their own models of being, and therapists will be at a considerable disadvantage in forming therapeutic relationships if they do not possess some awareness and competence within these specific fields of application. While person-centered therapists are empathetic, Lago suggests they may still enter a therapeutic alliance with prejudice towards difference. In the process of therapy, these therapists may inadvertently reinforce a client's experience of marginalization. A second criticism of PCT is that it is superficial. While critics suggest person-centered therapy is biased towards white, Western middle-class, and verbal clients, they also raise concerns about its efficacy. Kensett questioned the value in meeting a sociopath with unconditional positive regard, rather than direction or confrontation. If this client is incapable of self-actualizing, person-centered therapy may be ineffectual for him or her. In other words, critics posit that person-centered therapy may not be effective in treating major personality disorders. A third criticism of person-centered therapy is that alone it is incomplete. Within the therapeutic relationship, a client exists in an optimal environment. However, once the client leaves this space, it is unclear if he is able to maintain his gains in therapy. Kensett argued for more conclusive studies in this regard and suggested that therapists use person-centered therapy concurrently with other life skills training. On its own, Kensett believed person-centered therapy does not do enough for the client. As Kensett stated, with an eclectic theory, we can be assured that the client will reach their full potentials and remain socially congruent. In addressing the challenges of offering therapy in a multicultural setting, there are two important points to bear in mind. In person-centered therapy, personal qualities of the counselor are more important than specific techniques. And secondly, the difference within groups may be greater than the difference between groups. Rogers considered that there were 5 basic counselor qualities necessary for effective counseling. Some of these are universal and are related to respect for the individual. Others, such as 3 and 5, require knowledge specific to a culture. 1. Respect for the client. The client has the right and ability to self-determine. 2. Genuineness. The therapist is not the expert dispensing techniques, but a person offering genuine care. 3. Empathetic understanding. The therapist must be able to enter the world of the client with empathy and respect for the client's worldview. This step is especially vital in a multicultural setting and may be necessary for the therapist to truly engage with the client. The ability to convey empathy in a culturally consistent and meaningful manner may be the crucial variable to engage the client and to allow for self-disclosure, which is necessary for therapy to be successful. 4. Communication of empathy, respect, and genuineness to the client. The client must be able to receive the communication from the therapist, both verbal and nonverbal, but ultimately genuine respect, unconditional positive regard, empathetic understanding of another's perspective, as well as allowing a client to find their way to their own solutions, are traits which are not bound by culture. 5. Structuring. This element is quite important in multicultural counseling since the client may have little experience with therapy. Their experience in working with professionals may be primarily receiving instruction or advice. A well laid out structure will allow the client to understand their role and feel more confident to find solutions.